Before we get into the discussion of how we would approach this patient and our thoughts on this patient, it may be important to frame the discussion and talk about the recent data we have as it's relevant to this case. And the first piece of data that is relevant to this case is obviously the role of immunotherapy post-concurrent chemoradiation, which I think has altered our treatment paradigm in the last 6 to 12 months. This paper was published in the New England Journal of Medicine in 2017. It's the Pacific study. It was looking at more than 700 patients who had stage 3 locally advanced unresectable non-small cell lung cancer, who had a performance status of 1 or less, and if they had achieved at least stable disease after radiation, concurrent chemoradiation, they were randomized 2 to 1 to consolidation durvalumab, a PD-L1 drug every 2 weeks, versus placebo. The tumor and patient characteristics were well balanced between the two arms. Importantly, all PD-L1 patients were allowed. Patients were not allowed to get consolidation chemotherapy. They could get induction chemotherapy. And the PFS Kaplan Meier curves are shown here, and there was a robust benefit with the addition of consolidation durvalumab versus placebo. As it relates to PFS, the hazard ratio was 0.52, and there was a median PFS of 16.8 months versus 5.6 months. And it seemed like all benefits benefited. All subgroups benefited from the in the experimental arm. Patients that were smokers or non-smokers, 3A, 3B, squamous or non-squamous, patients did seem to have a benefit in progression-free survival. And there was an improvement in response rate as well with durvalumab versus placebo. And not surprisingly, there were adverse events encountered from the study, but I don't think any of us thought that this drug would be as well tolerated as it was, given so close to radiation. We didn't see a lot of pneumonitis from this trial. Grade 3-4 adverse events were not that frequent in the immunotherapy arm compared to the placebo arm. So that's one piece of data I think that's practice changing that we can talk about with this case, is the role of durvalumab benefiting all patients. Of course, this data has not, we know there's an overall survival advantage. We don't know what that is yet as of today, but certainly a meaningful benefit in PFS. The second data that point that I just want to talk about before we go back to the case is recently been published in the JCO in 2018, looking at the role of checkpoint inhibitors in patients who have pre-existing autoimmune disorders. This was a retrospective analysis from multiple institutions, including MD Anderson and Memorial Sloan Kettering, looking at 56 patients who had pre-existing autoimmune disorders who were treated with a checkpoint inhibitor. And these autoimmune disorders could be anything from rheumatoid arthritis to ulcerative colitis to multiple sclerosis. There were a couple of patients there. And for patients who had, again, these 56 patients, most of them were not symptomatic. These weren't patients that were having any sort of symptoms at the time that they were at least looked at in this retrospective analysis. And most of these patients also weren't requiring any sort of medications for their autoimmune disease. And, a small number of patients, 56 patients who received checkpoint inhibitors, only 23% developed, 13 patients, 23% developed a flare of their autoimmune disorder when treated with a checkpoint inhibitor. And I thought that was interesting. We can talk about how comfortable we feel in this case treating with immunotherapy. And the cumulative incidence or the exacerbation of the autoimmune disorder versus the cumulative incidence of death and disease progression, we see that most of these patients were allowed to continue on their treatment, and very few of these patients actually had any treatment long-term interruption with immunotherapy. So the take-home message from this trial was, this retrospective analysis was that you can reasonably, or it may be safe to give checkpoint inhibitors in patients with pre-existing autoimmune disorders, although I think that these are very small numbers of patients.